So I would like also to thank the organizing committee for the invitation. It's a real pleasure to be here today. Bon matin à tous. So that was not that harsh. I thought we would have a debate this morning, but we kind of agree on a lot of things. So it should make it easier for me now. I will give you my perspective on left main revascularization. I'm a cardiologist and I'm an interventionalist. I have no conflict of interest other than that one. The learning objectives will be to briefly review the historical perspective of left main PCI, interpret the new data available, determine the advantages of one technique over the other, CABG versus PCI, obviously. So I'm going to start with a little question for the panel. Anybody knows what event is celebrating its 40th anniversary this year in 2017? First PCI, that's a gimme, and that's an easy one. So obviously that was the first PCI ever performed by this guy, Andreas Grunzing, November 1977, on an LED, famous pictures that guy was recapped many years later, but it is also the 40th anniversary of the first left main PCI that was performed the same year in November, again, obviously by Grunzing. And in fact, the first 50 cases he published in '79, the New England Journal of Medicine, included 2 patients with left main PCI. And when you look at the anatomy, you kind of understand why Grunzing, with the type of equipment he had in those days, was kind of finding the left main attractive for angioplasty. It's obviously a large artery, it is proximal, it's straight, short length, so easy access with guide wires and balloons, especially the one he had when he started the PCI procedures. So what happened? What went wrong? Why did he stop? Why are we still debating that subject 40 years later? Many reasons. First of all, one of the patients he performed an angioplasty on, the left main, died suddenly 1 year after the procedure. And I read somewhere that he was quite obsessed with that patient. He was sure that he died because of left main thrombosis, although it has never been proven. It was also known for surgeons in those days that left main trauma with the cannula used during CABG could induce dissection and could be potentially harmful with a sudden death after the procedure, and they stopped doing that. In the same years, big studies like CAS, VACSS showed the benefit of CABG over medical treatment, so CABG became the gold standard of left main stenosis. We also recognize that it was not that easy to perform angioplasty on the left main. We all know that now that it's a bifurcation lesion in most of the time. So there are challenges. And also there were cohorts of patients that were published at the end of the 80s and the beginning of the 90s showing very poor results with angioplasty. So for many years, angioplasty was only offered to non-surgical candidates. But BMS and DES arrived and it changed everything. We regained an interest in left main angioplasty. And we also learned how to treat those bifurcations thanks to the French that taught me and a lot of us in the room today how to do it. Many studies have been published showing the safety and the efficacy of left main PCI, small studies, sub-studies, all showing non-inferiority of PCI versus CABG. However, many people found that those studies were too small, the margin was wide, so they were judged inconclusive. The guidelines were in that line. The AHA in 2005 stated that for CABG-eligible patients, PCI was a class 3 indication. They changed it a bit. Those are the last guidelines from the AHA, 2011, and they moved a little bit PCI to a 2A and 2B class indication depending on your syntax score. However, CABG is still the favored treatment over PCI, at least in the AHA guidelines. So 2016 was supposed to be the year for left main revasc with the publication of those 2 big studies, the Noble and the Excel study that were published less than a week apart last December. And as you all know, the primary endpoint in the Noble study was in favor of CABG with a hazard ratio of 1.48. But in the Excel study, The PCI group was judged non-inferior to CABG with a hazard ratio of 1. So basically, when you look at those two studies, if you're a cardiac surgeon, like Dr. Noiseau at my center, you're really happy with the result of the Nobel study. But if you're a cardiologist, interventionalist, like my good friend Stéphane, you're really happy with the Excel results, and you keep on doing what you do best, angioplasty. So instead of giving a final answer to that debate, those two studies were finally give more questions than anything else, and we will look deeper into the results, and maybe we'll find that the results are not that different in the end. So the designs of the two studies were quite similar. They're both big studies, prospective, randomized, multi-centered, non-inferiority studies. They included ACS and non-ACS patients, and the heart team was involved in both studies for patient selections. The follow-up was a little bit different. In the Excel trial, it was 3 years, planned 3 years. In the Nobel trial, it changed during the study. It was supposed to be 2 years at the beginning of the study, but because of a low event rate, they had to prolong the follow-up twice during the study, ended up at a 5 years follow-up, with approximately a third of the patient being followed for 5 years. The median follow-up in both studies are of 3 years, and it's identical. In the Excel trial, all of the DES stents were the Xion stents, a very efficient stent, a thin strut stent, a stent that we know very well. In the Nobel trial, 8% of the stent used were the first generation Cypher stent, and the other ones were the Biomatrix stent, which is a little bit thicker than the Xion stent. Syntax score was used to randomize the patient in the Excel trial, 32 and less to be included. In the Nobel trial, the syntax score was calculated by a core lab, but not used to randomize the patients. Instead, they defined the complex anatomy, and those patients with complex anatomy were excluded. The primary endpoint is very different between the two studies, the definition of it. So in the Excel trial, all-cause death, stroke, and MI, but MI including peri-procedural MI. It's very important to remember that. And in the Nobel trial, it was all-cause death, stroke, non-procedural MI. So MI that occur after CABG or PCI were not included in the endpoint, and repeat coronary revasc at 5 years. So those two primary endpoints obviously are different. We cannot compare that head-to-head when you discuss the data. Let's look at the results. The characteristics of the two populations were quite similar: age, gender, and risk factors. However, there was a little bit more diabetic patient in the Excel trial. It was performed in North America, so we have more diabetes here. More ACS patient in the Excel trial, and the syntax score calculated by the core lab was a little bit higher in the Excel trial than in the Nobel trial. Also identical, distal left main involved in more than 80% of the procedures. As we know, performing PCI on left main is always involving the bifurcation most of the time. IVUS often used, one stent technique recommended, and final kissing balloon inflation also recommended in both studies. The primary endpoint was different. I already said that, so I'm going to skip to the different issues included in the endpoint. All-cause mortality was similar, both in Excel and Nobel, so no significant difference in the two studies. Overall, the mortality was a little bit higher in the Nobel study, but no difference between the two groups. Also identical was the need for Revasc. In Excel, 12% versus 7.5. In Nobel, 15 versus 10. So a higher rate of Revasc needed in the PCI group at a rate of approximately 1.5% per year. Most of those Revasc were another PCI. 30 days outcome were also lower in both studies in the PCI groups, as was major peri-procedural adverse event with PCI, like bleeding, transfusion, infection, arrhythmia, and renal failure. The length of stay obviously was in favor of the PCI groups in both studies. And a major difference is here, MI. In the Excel trial, there was no difference between PCI and CABG in the overall follow-up. However, remember, they included the peri-procedural MI that would occur after CABG and PCI. In the Nobel trial, the MI rate was higher, a lot higher in the PCI group than in the CABG. So obviously, it influenced the primary endpoint. Another reason why the MI rate might be higher in the Nobel trial is the stent thrombosis rate, which is very high in the Nobel trial, 3%, 10 times higher than in the Excel trial. For a modern study, it's way too high. I don't know why, I don't know what's the explanation for that, but definitely it influenced the primary outcome. And finally, the stroke rate. Again, very different between the two studies. In the Excel trial, no difference between the two studies, but in the Nobel trial, a higher rate of stroke in the PCI group compared to CABG, which is, I mean, in my opinion, weird to explain. And when you look at the time analysis, you realize that it was after 1 year of follow-up that the curve begins to separate with more event in the PCI group. And I don't think there's any logical, physiological explanation for that. It has to be related to chance, but obviously, again, it played a role in the final endpoint. So what can we conclude with those two studies? First of all, I'm not sure there will be other studies comparing PCI and CABG for left main revas, so we have to deal with what we have. And with what we saw for eligible patients with left main disease, PCI is non-inferior to CABG regarding mortality. CABG is associated with more adverse periprocedural events in the first periprocedural events and in the first 30 days. And PCI will be associated with an increased risk of repeat revasc at a rate of approximately 1.5 per year. Obviously, longer follow-up will be interesting. I think that the guidelines should be adapted, broadening the patient pool eligible for PCI, always based on a heart team evaluation, obviously, regarding the comorbidity, life expectancy, etc., but always also take into account the patient preference, because your patient might interpret those data differently than you are. So to conclude, medicine is constantly evolving. Obviously, we now can offer less, let's say, aggressive way of treating our patients. And I strongly believe that anytime a less invasive strategy is non-inferior to a more invasive one, if you're the patient, it is already superior. Finally, the patient I presented you at the beginning of the study at the beginning of my talk, got his left main stented. I'm still following him and is doing perfectly. Thank you.